Bismillahirrahmanirrahim. Today we will be discussing approach to pain abdomen in OPD. We have already covered how to approach the patient presented with abdominal pain. Then we have specifically covers how to construct a diagnosis of pain abdomen presenting in emergency department. Now we will be discussing inshallah pain abdomen in patient presented in outpatient department. So patient presented in OPD usually have a chronic abdominal pain. They usually present you with long-standing abdominal pain or recurrent attacks of abdominal pain. But if someone present with acute abdominal pain in OPD, you have to approach this patient similarly as you approach someone in emergency department. You have to rule out all the red flag diagnosis first before you move towards the chronic medical conditions. So chronic abdominal pain, there are few terminologies that you have to know before you classify or approach the patient, someone with chronic abdominal pain. So what is chronic abdominal pain? That is episodic pain lasting at least 1 month, but more commonly more than 3 months. कम से कम 1 माह हो चुका हो पेशेंट को abdominal pain की complaint के साथ जो. Then recurrent abdominal pain, this is another terminology. Patient presented with at least 3 episodes of pain over at least 3 months that are severe enough to affect the ability to perform normal activities. Last 3 months में कम से कम 3 presentations हों पेशेंट की with severe abdominal pain जो कि उसको नॉर्मल रूटीन एक्टिविटीज़ परफॉर्म करने में मुश्किल पैदा करें. Non-specific abdominal pain, that is episodic abdominal pain with no association with any gastroenteritis and normal abdominal or physical examination. That is non-specific abdominal pain. Patient has no organic pathology and abdominal examination is also normal, but patient is complaining of some episodic abdominal pain of variable severity. Then lastly and most important thing that you have to know while approaching the patient with abdominal pain in OPD is functional, non-organic or psychogenic abdominal pain. Abdominal pain in absence of anatomic abnormality, inflammation or tissue damage. So there is a very high chance that physicians classify chronic abdominal pain as a functional pain. There are many times we have seen the diagnosis of functional abdominal pain in the patients who have some sort of anatomic abnormality or some sort of inflammation. So you have to keep the threshold for diagnosing someone with functional abdominal pain very high. You have to rule out all the anatomic causes, inflammatory causes first before saying that this patient might be having some functional abdominal pain or functional cause. So this is the algorithmic approach that we will be discussing today about chronic abdominal pain. In the center, this is the definition of chronic abdominal pain: long-lasting, intermittent or constant abdominal pain that is due to either organic or functional cause. We have discussed various forms of chronic abdominal pain in a previous slide. First of all, as we have already discussed the approach to abdominal pain, so first thing first is history. So on history, you have to follow the same pattern that we have discussed in previous lectures. First you have to do the locura, then with the help of associated symptoms you have to construct the differential diagnosis. Then you have to ask about the drugs, toxins, including smoking and illicit drug abuse, endocrine history, connective tissue disorders, family history and psychiatric history as well. So when you take the history and you follow all the protocol, these are the red flag signs. These are the red flag signs that we have to keep in mind. If you found any one of these, you have to stop and note it down and think about the organic cause first. So what are the red flag signs? The right upper quadrant or right lower quadrant constant pain. So it's not specific to right upper or right lower. any quadratic pain, अगर किसी एक quadrant में patient को constant pain हो रहा है, it's very less likely that it's functional in origin, कि वो functional वो pain जो है ना, it has to be some organic cause underlying. Like if a patient has persistent or recurrent right upper quadrant pain, that patient might be having some biliary cause, like biliary colic, cholecystitis, like choledochal cyst. These patients present with right upper quadrant pain. Similarly, right lower quadrant pain, patient might be having some adnexal cysts. The patient might be having recurrent UTI and having some pelvic pathology like tubular abscess, salpingitis, endometritis, things like that. The patient has pain in some specific quadrant, think of some organic cause rather than the functional cause. Pain wakes the patient from sleep. अगर दर्द मरीज को नींद से उठा देता है, it's again very less likely that patient is functional in origin, or the pain is functional in origin. So you have to find the organic cause, underlying organic cause. If the patient's pain aggravate with meal, wheat, milk, or exertion, these are some 4 important triggers that we have to specifically ask while approaching patient with abdominal pain in OPD. अगर मरीज कहता है कि मुझे खाने से दर्द बढ़ती है, खाना खाता हूँ बढ़ जाता है दर्द, patient might be experiencing gastroesophageal reflux disorder, eosinophilic esophagitis, gastritis, peptic ulcer disease, some pancreatic disorder, because all these conditions, in all these conditions, patient's pain usually worsen with meal. Or specifically, if the patient says that his condition or his pain worsen after taking wheat, that specifically occurs in celiac disease, or milk, like in patients with carbohydrate intolerance like lactose intolerance. Or if the patient says that his pain worsened with exertion, that is again a red flag sign. If the patient says he has some upper abdominal pain or epigastric pain that worse while doing some activity or moving or climbing uphill or taking stairs, that means the patient might be having stable angina. So aggravation of pain with meal, wheat, milk, or exertion is very important thing that you need to ask in patient while approaching abdominal pain. Intractable vomiting or bilious vomiting. If the patient presents to you with multiple episodes of vomiting or especially bilious vomiting, this is again a red flag signs that either shows the patient has some intestinal obstruction like subacute intestinal obstruction, or patient with pancreatitis usually present with these episodes of intractable vomiting. Patients with chronic cholecystitis usually presents with the episodes of intractable vomiting or bilious vomiting, things like that. Heartburn or regurgitation, usually gastroesophageal reflux disorder, or eosinophilic esophagitis, patient presents with heartburn or regurgitations, metastasis or melena. So bleeding from any side is a red flag sign. If the patient presents to you with blood in the vomitus, or black tarry stools, or fresh blood in per rectum, or hematuria, or epistaxis, blood from any orifice is a red flag sign. So it's a general thing. So if the patient presents to you with hematomesis or melena, it's a red flag signs for patient presented with abdominal pain. Diarrhea with pus, blood, or fat in the stools. So that means that patient is experiencing some inflammatory enterocolitis. So if the patient has diarrhea that and the pus contains and the stool contains pus, blood, or fat, then it's again a red flag signs. Constipation, severe constipation usually cause abdominal pain, cramping. Constipation might be a functional problem and it might have some organic underlying pathology as well. Mass in the abdomen. If the patient says that he experienced some swelling in typical at one specific area of the abdomen, then it's again a red flag sign. It might shows herniation or some malignancy. Fever is a red flag sign again in all cases. When you approach someone with any particular symptom and the patient experience fever as a comorbid symptom, then it's a red flag sign as well. Fever shows that the patient has underlying inflammation or some malignancy or some infection going on. It's not a functional problem anymore. weight loss of more than 10% in the last 6 months. So it's a very important thing that we have to quantify the weight loss. If the patient says that he has lost some weight, कि उसने कुछ वजन कम किया है, you have to ask specifically how much weight loss is there. That has to be more than 10% in last 6 months. So if the patient has weight of 60 kg, he has to lose almost 6 kg in last 6 months to quantify it's a pathological problem. 1 or 2 kg weight loss is not significant. It might occur in functional problem as well. Pallor, lymphadenopathy. Patient specifically says that he experienced some lumps or bumps in the neck region, in the upper chest, in axilla, in the groin region. You have to specifically ask कि आपका रंग फीका तो नहीं पड़ रहा है पैलर के लिए, या आप जिस्म में गिल्टियाँ महसूस तो नहीं करते हैं, ख़ास तौर पे गले में, बगलों में, ग्रोइन के एरिया के अंदर. स्किन रैशेस, any skin rashes, especially along the shin areas and anyway, skin rashes again indicate some organic pathology. So you have to specifically inquire about the details of these rashes. The patient might be having erythema nodosum that occurs in inflammatory bowel disease, pyoderma gangrenosum again in inflammatory bowel disease. Some paraneoplastic syndromes have rashes like ichthyosis. These usually occur in upper GI malignancies, and patient might be having some purpuric rash that occurs in shawl and purpura, that also present sometimes with abdominal pain. So vasculitic conditions, connective tissue disorders can present with skin rash and abdominal pain as well. So skin rash is very important associated feature in a patient presented with abdominal pain. Recurrent attacks of dysuria and flat pain. So patients with pyelonephritis, patients with recurrent UTIs usually also complain about recurrent attacks of dysuria and flank pain along with abdominal pain. Menstrual irregularities, especially in females of reproductive age, you have to specifically inquire about menstrual cycle, pain during the periods, pain during intercourse, PV discharge, and PV discharge, color, and whether it's foul smelling or not. So these are specific questions that we have to ask in females, especially females of reproductive age. If they have these problems along with abdominal pain, that patient might be having dysmenorrhea, endometriosis, pelvic inflammatory disease, ovarian cyst, pelvic malignancy. So you have to think that lines if you found any one of these symptoms along with abdominal pain. You have to specifically ask about drugs like chronic NSAID abuse that might lead to peptic ulcer disease, rectal ulcers, colorectal ulcers, toxins like ask about chronic active or passive smoking history, opioid, any illicit drug abuse, organophosphate poisoning, and other environmental toxins as well. Endocrinopathies like hypothyroidism, diabetes mellitus. Specifically ask about the symptoms of hypothyroidism or diabetes, or family history of hypothyroid dysfunction or diabetes mellitus, connective tissue disorders, and family history. So if you found any one of these things while approaching the patient on the pattern of Lokira, then you have to ask associated symptoms, drug, toxin, endocrines, connective tissue disorders, family history, psychiatric history, and you find one of these red flag signs, then you correlate these red flag signs with the differential diagnosis mentioned in the extreme left corner to get to your diagnosis. Then examination. Again, we have to follow the same scheme that we have discussed before, and while examining the patient on the same lines, if you find a patient with a wasted look, pale, jaundiced, clubbing, and specifically you have to look for stigmata of CLD that includes pulmonary erythema, some scratch marks over the body, spider angiomas, gynecomastias, distended abdomens, atrophied testes, pedal edema, and wasting of temporal muscles. These are the stigmata of chronic liver disease. So you have to specifically look while doing the general physical examination. All these are red flag signs. They shows organic pathologies rather than functional cause. Any abdominal tenderness, any abdominal mass, hepatomegaly, splenomegaly, ascites, rectal examination showing hemorrhoids, fissure, and rectal mass. All these things on physical examination indicate the organic pathologies as well. So if we find massive splenomegaly or massive hepatosplenomegaly on physical examination, then you have also need to consider lymphoproliferative or myeloproliferative disorders as well. I haven't mentioned these in the differential diagnosis list, but it's very important thing to consider. These patients with myeloproliferative disorders like CML, they present with dragging pain, dragging upper abdominal pain on walking and on sitting, changing posture. So you might find patients with abdominal pain with hepatomegaly or splenomegaly with underlying diagnosis of myeloproliferative disorders as well. So on physical examination, you have to look for the evidence of wasting, pallor, jaundice, clubbing, stigmata of CLD, and on abdominal examination, feel for abdominal tenderness, feel for any abdominal mass, hepatomegaly, splenomegaly, and ascites. Then go for rectal examination and look for any hemorrhoids, fissures, and rectal mass. I haven't mentioned it, but you have to do the pelvic examination as well in females who give any specific history of menstrual irregularities, painful periods, or PV discharge, or painful intercourse as well. So, based on the history and physical examination, you have to construct the diagnosis, and then you have to investigate to confirm your list of differential diagnosis. So, if you have a patient presented with upper abdominal pain and you find any specific red flag signs that features gastroesophageal reflux, that includes heartburn, regurgitation, so you have to consider it as a diagnosis. Eosinophilic esophagitis, that patients usually have upper abdominal discomfort, heartburn, regurgitation, that usually doesn't respond to your usual treatment, and these patients present with symptoms worsening after ingesting these particular things like milk, soya, eggs, and fish proteins. Similarly, peptic ulcer disease, if the patient has epigastric pain, that usually worse after taking meal, or in case of gastritis, or worse during in between meals or after 2 or 3 hours of taking meal. In case of duodenitis, that the patient might be having peptic ulcer disease as well. Pancreatic disorders, including acute or chronic pancreatitis and pseudocyst, these patients usually have upper abdominal pain and vomiting and previous history of pancreatitis. Gallbladder disease, including cholelithiasis, cholecystitis, choledochal cyst. So these patients usually have upper abdominal pain, especially right upper abdominal pain with episodes of vomiting, right upper abdominal tenderness as well. So you have to consider gallbladder diseases as a differential in your differential if the patient has upper abdominal pain with vomiting episodes. Then chronic hepatitis, hepatic malignancy. These patients present with upper abdominal pain, jaundice, and hepatomegaly, and upper abdominal pain, tenderness, wasting. There might be some evidence of stigmata of CLD, splenomegaly, ascites as well. Any patient presented with upper abdominal pain, these 5 or 6 things that you have to keep in mind and rule out before labeling the patient as functional bowel disease. So the patient might be having gastroesophageal reflux, the patient might be having eosinophilic esophagitis, the patient might be having peptic ulcer disease, the patient might be having pancreatic disorders, gallbladder disorders, or chronic hepatitis or hepatic malignancy. Then lower abdominal pain. We have some a bit long list of differential diagnosis in patients presented with lower abdominal discomfort. So the patient might be having some worm infestation, usually children presents with the non-specific general diffuse or lower abdominal pain with worm infestation. These children are usually pale and they give you history of eggs or worms in their stools or pruritus ani. Then inflammatory bowel disease. These patients usually have abdominal pain, lower abdominal pain, along with bloody diarrhea or diarrhea containing pus, blood, or mucus in their stool. And these patients are usually pale. They have history of fever. They have history of weight loss as well. And they have extra intestinal symptoms like arthritis, skin rashes, uveitis as well. And constipation, chronic constipation usually also presents with non-specific abdominal pain as well. Recurrent intussusception, again, children usually present with these presents with abdominal pain and constipation. You have to consider recurrent intussusception as a differential diagnosis. Meckel's diverticulum, again, in children presented with recurrent abdominal pain and some bloody diarrhea, you have to consider Meckel's diverticulum as your differential diagnosis as well. Intestinal lymphoma, uh, these patients usually have a non-specific abdominal pain or lower abdominal pain along with abdominal mass like ileocecal mass or abdominal lymphadenopathies. And on history you might find evidence of fever, weight loss, pallor, lymphadenopathies as well. And the patient might be wasted, he might be having pallor, and then you will order ultrasound and find some intestinal mass or abdominal lymphadenopathy that might leads you to a diagnosis of intestinal lymphoma. Herniation, groin or umbilical herniation might present with lower abdominal pain or discomfort. Colorectal cancer, yes, if any patient with new onset lower abdominal pain in age about 50 years, and he has some altered bowel habits, he's pale, he's wasted, then you have to consider colorectal carcinoma as well. Renal calculi or hydronephrosis, again, if the patient has flank pain or recurrent attacks of UTIs or dysuria, then you have to consider renal calculi as well. Recurrent urinary tract infections, again, patient presented with recurrent attacks of dysuria, flank pain, you have to consider recurrent UTIs. Gynecological problems like dysmenorrhea, endometriosis, PID, ovarian cyst, pelvic pregnancies, any female with lower abdominal discomfort along with menstrual irregularities, pain during periods, or some PV discharge, some pain while doing intercourse, then you have to consider these etiologies as underlying cause as well and have to investigate on these lines as well. Diffuse abdominal pain, yes, if the patient has diffuse abdominal pain, then first thing first, you need to rule out the celiac disease. These patients usually give history of wheat intolerance, that they are unable to take wheat in their diet, or they might give you history of nausea, anorexia, and they might give you history of bulky, large volume of fatty stools that are difficult to flush. But sometimes there is no other complaint. The patient only has some diffuse abdominal pain that doesn't fit in any other diagnosis, and the only other few things that you might find is the patient uh, has some wasting and he's not gaining the weight, or he's losing some weight, and you have to consider celiac disease as a differential diagnosis as well. It's a very common thing, and it's very neglected thing as well. Always consider celiac disease in your differential while taking history or approaching the patient with diffuse abdominal pain. Carbohydrate intolerance like lactose intolerance, fructose or sorbitol, diabetes mellitus, sickle cell disease, lead poisoning, porphyria, collagen vascular diseases. These patients, it's a very rare diagnosis, not very common entities, but we have to keep in mind while approaching the patient with diffuse abdominal pain. So, after taking the history and physical examination and give a very thoughtful insight on these differential diagnoses, then you have to order the investigations to confirm your findings, to look for any complications associated with these differential diagnosis as well. So always send complete blood count, C-reactive proteins, ESR. This will give you an insight about whether the patient has any ongoing anemia or ongoing inflammation, which will gives you clue about pancreatic conditions, cholecystitis, inflammatory bowel disease, worm infestations, and malignancies like pancreatic, biliary or colorectal malignancies, gynecological malignancies. In all these conditions, you will get a very high ESR or CRP levels. Urine and fecal microscopy. Yes, always send for urine complete examination in a patient's suspecting renal calculi or recurrent UTIs. Then fecal microscopy, it will gives you very good insight about the patient has any worm infestation, any inflammatory bowel disease, also in Meckel's diverticulum. Then you will get some occult blood, you will get some pus, ova, cyst, parasites on fecal microscopy. Celiac disease testing. If you have a suspicion of celiac disease, send anti-TTG IgA levels and total IgA levels as well. Test for H. pylori if the patient has predominant epigastric pain. Go for upper GI endoscopy if the patient has resistant dysphagia, recurrent epigastric pain, or suspicion of eosinophilic esophagitis or gastritis. Lower GI endoscopy for persistent enterocolitis. Then abdominal ultrasound. It's a very important modality or initial test to rule out any secondary or organic pathology in upper abdominal, lower abdominal or diffuse abdominal pain. You will get a good insight about many differential diagnoses on abdominal ultrasound, like if you have very good or latest machine available, you can get an insight about chronic pancreatitis or pseudocysts, any gallbladder disorders like cholelithiasis, cholecystitis, colorectal cyst, evidence of chronic liver disease, any focal lesions that might indicate hepatic malignancy. You might get an evidence of inflammatory bowel disease. You might get an evidence of impacted stool. You might get an evidence of any colorectal mass or malignancy sometime on ultrasound. You might get an evidence of renal calculi or hydronephrosis, and you might get an evidence about pelvic inflammatory disease, any ovarian cyst or pelvic malignancy on ultrasound as well. In order to confirm your diagnosis, especially if you are suspecting any malignancy, then you have to order the CT abdomen and pelvis contrast. So your investigation must be tailored what based on what you find on history and physical examination, and what you are suspecting based on your history and physical examination. If you didn't find any red flag signs, and if the physical examination is also unremarkable, and basic screening that includes CBC, CRP, ESR, urine and fecal microscopy, and ultrasound comes back normal, then that patient might be having functional bowel disease. So functional bowel disease classified into 4 further types. You have to fulfill the criteria to fit the patient in any one of 4 differential diagnoses. So the patient might be having functional abdominal pain. This entity requires the patients presented with at least 4 times in a month for at least 2 months, and includes episodic or continuous abdominal pain not associated with eating or menses, and does not meet the criteria for pain with abdominal migraine, dyspepsia or IBS. So when will you say the patient has functional abdominal pain, or when will you label the patient having functional abdominal pain? अगर उस मरीज को महीने में कम से कम 4 दफ़ा पेट में दर्द हो और कम से कम 2 माह तक हो, दैट इंक्लूड्स एपिसोडिक और कॉन्टिन्यूस, या तो वो एपिसोड्स में आए या मुसलसल हो, और ना उसका कोई ताल्लुक खाने से हो या मेंस्ट्रुअल साइकिल से हो, और ना ही वो एब्डोमिनल मिग्रेन, डिस्पेप्सिया और आईबीएस का क्राइटेरिया पूरा कर रहा हो, तब हम उसको फंक्शनल एब्डोमिनल पेन लेबल करेंगे. The pain that occurs at least 4 times in a month for at least 2 months, either episodic or continuous, not associated with eating or menses, and does not meet criteria for pain with abdominal migraine, dyspepsia, or IBS. That is functional abdominal pain. Second thing is abdominal migraine. That is at least 2 episodes over 6 months of intense periumbilical, midline or diffuse abdominal pain, lasting for more than 1 hour and affecting your normal activities, and pain associated with 2 or more additional symptoms like nausea, vomiting, anorexia, headache, pallor, or photophobia. So all these symptoms occur during the episode of pain, not in between the pain. So 2 episodes over 6 months of intense periumbilical, midline, or diffuse pain that lasts at least for more than 1 hour, and pain is so much intense that it affects your normal activities and is associated with 2 or more other symptoms along with pain like nausea, vomiting, anorexia, headache, pallor, or photophobia. ये याद होने चाहिए आपको. अगर याद नहीं है और क्राइटेरिया पूरा नहीं हुआ, you can't label someone with abdominal migraine. IBS, that is abdominal pain at least 4 days a month for at least 2 months. 4 days a month at least 2 months, that is associated with defecation or with change in frequency or form of stools. In children with constipation, pain does not resolve with resolution of constipation. So IBS हम कब कहेंगे? अगर पेन महीने में 4 दफ़ा हो, कम से कम 2 माह तक हो, दैट इज एसोसिएटेड विद डेफिकेशन, मतलब पेन का डेफिकेशन के साथ ताल्लुक हो, मतलब पेन है एंड द पेशेंट डेफिकेट्स एंड द पेन लीव्स, और विद चेंज इन फ्रीक्वेंसी एंड फॉर्म ऑफ स्टूल्स, या अल्टर्ड बावल हैबिट्स का पेशेंट कहे कि कभी कॉन्स्टिपेशन हो जाती है पेन के साथ, और कभी लूज मोशन लग जाते हैं मुझे, ये कभी नॉर्मल हो जाता है. और अगर उसको कॉन्स्टिपेशन है, स्पेशली बच्चों में अगर उसको कॉन्स्टिपेशन है, पेन कॉन्स्टिपेशन के बेहतर होने से रिजॉल्व ना हो, या पेन का कॉन्स्टिपेशन के रिजॉल्व होने से कोई ताल्लुक ना हो, these are 3-4 things that you have to meet before labeling the patient with IBS. So abdominal pain at least 4 days a month for at least 2 months, that is associated with defecation or with change in frequency or form of stools, or in children with constipation, pain doesn't resolve with resolution of constipation. Lastly, functional dyspepsia, that is postprandial. आमतौर पे आप देखते हैं पेशेंट आते हैं कि जी खाना खाया, खाना खाने के बाद पेट आफर जाता है, फूल जाता है, खाना हजम नहीं होता, जल्दी पेट भर जाता है, 4-5 लुकमे लेता हूँ या लेती हूँ, साथ ही पेट फुल हो जाता है मेरा, या उसको एपिगैस्ट्रिक पेन हो, लेकिन पेन नॉट एसोसिएटेड विद डेफिकेशन ऑन मोर देन 4 days per month for at least 2 months. ठीक है. Patient will complain of postprandial fullness, early satiety, epigastric pain for more than 4 days a month for at least 2 months. So कमोबेश functional abdominal pain, IBS और functional dyspepsia का क्राइटेरिया मिलता जुलता है, लेकिन किसी हद तक थोड़ा बहुत उसके अंदर फ़र्क आ रहा है. And all these syndromes comes under the one bigger spectrum, that is functional bowel disease, जिसमें underlying कोई organic या स्ट्रक्चरल या इन्फ्लेमेटरी काज आपको नहीं मिलती है उस पेशेंट के लिए. एंड बिफोर लेबलिंग समवन विद फंक्शनल बाउल डिजीज, you have to rule out the organic cause first. This is for approach to abdominal pain in OPD, and I hope after listening to all these 4 lectures, you will come up with your own approach to taking history to and examining the patient and constructing the diagnosis in patient presenting with abdominal pain. Thank you very much.